Keys of Keys Life Safety and our very own Compliance One group. Brad has over 30 years of experience in the healthcare facilities management and joined our Compliance One team in 2016. Brad's expertise is in the management of the life safety program, which all of you know includes the environment of care and emergency preparedness. For all of you joining us today, you have joined in the listen-only mode, which means all of you are muted, so you need not worry about that. Yet we encourage you to type in any questions you may have throughout the presentation. There's a question pane on your screen if you want to familiarize yourself with that as I'm speaking here. And if you'll type in your questions as we go, we'll answer them at the end of the presentation for you. And if you need any further assistance with any of your emergency preparedness needs, my Compliance One information will be available at the end of the presentation. Feel free to reach out to me, and we'll get all of your issues handled with the assistance of Brad if need be. Now I would like to turn this webinar over to Brad Keys. Brad, are you with us, sir?
Yeah, go ahead, Joe.
Brad, appreciate you being with us today. We have a rather large audience of about 180 attendees, so we're all looking forward to listening and hearing your expertise and as you guide us forward in this ever drastic change for some, as you know. Long-term care folks that have joined us in some of the surgery centers, this is all new to them unless they're hospital affiliated. Those at the hospital that joined us, this will be a great touch-up and opportunity for you to pick Brad's brain as he knows a lot about this topic and has got vast knowledge and experience in this. So, Brad, thank you for joining us, and it's all yours, my friend.
Thank you very much, Joe, and welcome to everybody. I come to you today from northern Illinois, where it's a bright, sunny day, very warm. These are the days that we were longing for in January, so we're very happy to have the lovely weather. The learning objectives today is that at the conclusion of this program, we hope that you understand that the new standards from CMS apply to all healthcare occupancies, I should say facilities. We want you to identify the new requirements for the healthcare occupancies that accreditation organizations may not include. And we want to explain when their facility has to be compliant with the new requirements. And we want you to realize that the AOs may have more restrictive requirements than what CMS actually requires. Now, the following presentation is not a complete list of all the changes caused by the new emergency management rule that CMS has published, but we included the ones that we felt were the most common ones that will affect the operations of your facility. Last year in September, CMS issued their final rule on standards, new standards for emergency management that do apply to all healthcare facilities that receive Medicare, Medicaid reimbursements. Now, this final rule set the date of November 15th of 2016 when it becomes effective, but they also said that healthcare providers have until November 15th, 2017 to be in compliance. So essentially they're just giving all the hospitals, all the organizations, surgery centers and so forth a full year to become compliant. And that's a wonderful thing. We're really pleased that CMS has allowed a full year to get this information out. It also allows time for the accreditation organizations to rewrite their standards and get that information in for approval to CMS so that they can release them and have their clients start to become compliant. Now, CMS has developed many websites that assist the organizations in becoming compliant with the new rule. Now, these websites include checklists, links to other agencies and templates and other resources. This particular website has information about templates and resources that organizations could use. So these websites, you should probably print a copy of the presentation in order to get this information down. In addition, this website is from the Medicare Learning Network, which CMS hosts it was a call to discuss the requirements of the new regulation and answer questions. This was recorded, this conference call was recorded, and transcripts are available on this particular website. And then CMS has created an FAQ website that lists all these frequently asked questions on here. And then finally, if you care to download the actual final rule, be careful because it's over 600 pages long, you're welcome to do so at this website. Now, it's important to understand that CMS created a new set of standards for emergency management for all of the different providers and supplier types. Now, this includes acute care hospitals, critical access hospitals, ambulatory surgical centers, nursing homes, limited care facilities, all these different types of providers that CMS certifies through their Medicare or Medicaid program. They have created new standards. Now, in the language that CMS uses, they refer to standards as conditions of participation, or for ambulatory surgical centers, they call them conditions for coverage. But essentially, that could be explained as standards. Those COPs, or conditions of participation, are simply just standards. Standards that you have to comply with if you want to receive Medicare and Medicaid reimbursements. For the purpose of this presentation, we are going to focus on the acute care hospitals. But please understand that critical access hospitals, the standards are nearly identical. The only difference that I can recall off the top of my head is that the critical access COPs don't deal with transplant hospitals. And the standards for ambulatory surgical centers are nearly identical to almost identical to acute care requirements. So essentially the content of what we're going to be talking about today translates across the board from acute care to critical access to surgical centers as well. Now, before issuing this final rule, CMS had very little to say about emergency management. And in fact, all they really said in the COP for acute care hospitals is that emergency management is responsibility of the hospital to assure the safety and well-being of patients by implementing appropriate emergency preparedness plans and capabilities. And as you can imagine, that if that's all they said about emergency management, that's rather vague and non-descriptive as far as details. So essentially, it was never, for the most part, it was never enforced by any of the state agencies that conducted validation surveys on behalf of CMS, because there just really isn't a whole lot to evaluate according to that statement. So for the most part, healthcare facilities that were accredited by one of the national organizations actually had definitive requirements to follow regarding emergency management. Joint Commission, HFAP, D&V, all of these national organizations that do accreditation had already created their own standards on emergency management that were above and beyond and exceeded the minimum requirements that CMS had created. So hospitals that were accredited by one of these national organizations more likely are familiar with these terminologies, and quite honestly, you're probably at least 80% already compliant with these new final rule requirements, if not more. But hospitals that were not accredited by one of the major accreditations, and there are quite a few of them out there, they relied upon the state agencies for certification for Medicare and Medicaid reimbursements. Those hospitals may not be as familiar with the terminology and the concepts of emergency management, because essentially nobody's really held them accountable for any level of compliance. So those hospitals may have a real challenge in getting up to speed on what the new requirements are. But with the recent natural disasters that have affected the United States, CMS decided it was time that all healthcare providers and suppliers have the same set of standards regarding emergency management. So that is why CMS decided to create a brand new set of standards and assign separate COP numbers for all the different providers. And from my own personal standpoint, I think this is a good idea. I think it's time that we have a clear baseline as to what the expectation is, and across the board from your accreditation organization to your state agency and so forth, that everybody says, okay, at a minimum, this is what you have to comply with. And everybody, now it's firmly established, effective November of this year, that you have to comply with these things, and it sets a minimum standards. And quite honestly, I think that's terrific. Now, generally speaking, the CMS emergency management standards are not as in-depth and detailed as the accreditation organization requirements. So one might say that the AO requirements on emergency management are much more restrictive, and I would agree that would be a correct statement. Now, I do have a handout that hopefully you've already printed off, and this provides a comparison, an overview between the new CMS final rule and last year's emergency management requirements for Joint Commission, HVAP, and then the 2012 edition of NFPA 99. Now, the reason why I put in the 2012 edition of NFPA 99 is because that is what D&V requires compliance with. So this is just an overview. And if you look at your handouts, if you printed that, you'll see that there's quite a few things that the new CMS final rule actually requires, I should say, that does not require, that the other three does require. Now, if you start at safety and security and you look at staff support needs, exterior utility connections, triage, business continuity, incident command center, decontamination, mitigation, recovery, these are all things that the new CMS rule does not require. But the last year's standards for Joint Commission, HVAP, and NFPA 99 did require, or does require. So you can see that from a general overview, the accreditation organization actually has a little higher level of standards on emergency management than what CMS is proposing, and that's okay. CMS does require a few things more, especially on integrated health systems and transplant hospitals, that the accreditation organizations do not have. So you want to be familiar with what is provided, what is required. If you are accredited, you want to fully understand what your accreditation organization is and is not requiring, so that when the CMS requirements become effective, that you add to your programs to comply with that as well. So it shows that the standards don't require everything the Joint Commission requires. The new final rule doesn't require everything. So that was the point of that handout. All right, so let's make a transition, focus on the actual core elements that CMS has based their new standards on. CMS says that there are 3 key essential requirements for maintaining health services during an emergency. So this is what they base their program on, is number 1, safeguarding human resources, number 2, maintaining business operations, and number 3, protecting physical resources. So they are establishing their emergency management program, everything that follows on these 3 concepts. Now, before we get into the details, it's important to point out that CMS uses different terminology than what you may be already familiar with, because accreditation organizations sometimes use different terminology. So where the AO may say emergency management, well, that's the same thing as what CMS says when they say emergency preparedness. That's one and the same. When they talk about the emergency plan, they're talking about the emergency operations plan, which is also referred to as the emergency management plan, which is also referred to as the disaster plan, and in some cases they just call it the plan. When CMS refers to a risk assessment, they are referring to a hazard vulnerability analysis. So many of the accredited organizations are already familiar with the concept of a hazard vulnerability analysis. But ironically, for whatever reason, CMS doesn't call it that. They call it the risk assessment, but it's one and the same. Emergency is the same thing as saying a disaster, and staff refers to just about everybody in your facility with the exception of patients and visitors. So it covers employees, volunteers, students, physicians, chaplains, and any individual providing services under a contract. So that could be physicians, but it also could be your HVAC repairman. So you got to be very careful about who you're referring to when you refer about staff. Now, the overall program that we're referring to today is called the Emergency Management Program. and it covers all aspects of the program. So the emergency operations plan is just one aspect of the emergency management program. And the communication plan is just one aspect of the emergency management program. So when CMS refers to the emergency management program, they're talking about the big umbrella that all these other things fall under. Now you're going to notice that CMS does not subscribe to the 4 phases of emergency management that Joint Commission and NFPA does refer to. So what Joint Commission and NFPA refers to is mitigation, preparedness, response, and recovery. Well, you'll notice that CMS does not subscribe to mitigation and recovery. They feel that their standards should focus primarily on preparedness and the response to a disaster. They do not, they specifically say in their final rule that they do not build their program on any part of mitigation or recovery. So CMS replaced those elements with their own 4 core elements that cover planning, policies and procedures, communication, training, and testing. So it's important to understand that CMS does not believe that the EM standards should include business continuity. They want their standards to focus on operations, not recovery. Now you may find that after your accreditation organization publishes their final updates to their standards that they will continue to include business continuity. And that's their prerogative. They're welcome to do that. But just be aware that CMS is focusing on operations, not on recovery. So let's transition into the planning phase. CMS will expect facilities to track their on-duty staff and sheltered patients during an emergency. So essentially that just means that you have to know who's in the building, who's on duty, where the patients are at. And if the patients are relocated during the emergency, then you need to track that as to where they went and what went with them as far as records and who went with them. So that we'll cover a little bit more about that in the evacuation phase. So CMS will also expect the facility to include in its emergency plan a method for contacting off-duty staff during emergency. So oftentimes hospitals just use a call-up tree, if you will, on what the on how to contact the off-duty staff. But the approach is that you have to have a plan on how you're going to contact these off-duty individuals. Now, prior to establishing an emergency operations plan, so this is before we even talk about the EOP, you must first do the hazard vulnerability analysis, what they call a risk assessment. Now, the emergency operations plan is actually based on the risks identified in the HVA. It must have strategies for addressing the emergency events identified in the HVA. So that's why you do the HVA first. You have to conduct the analysis on on how vulnerable you are to the expected disasters that could occur to you. This evaluation has to be updated on an annual basis. That's one thing that may be a little bit different than your previous accreditation organization, is that anything to do with emergency management has to be reviewed and updated on an annual basis, whereas some AOs in the past have allowed that to happen once on a triennial basis, every 3 years. So CMS is setting the standard a little higher in that area, and they want everything updated. Every policy, every plan, every analysis has to be updated on an annual basis. And as far as I know, at this point, annual means during the calendar year. That may change based on the interpretations of the accreditation organizations. So the emergency operations plan, the EOP, must address the type of services the hospital will be able to provide in emergencies. So if you decide during an emergency you're going to curtail certain services in order to consolidate staff and open up resources, that's fine. But you need to be able to say that in your EOP, and you have to actually communicate that to your regional emergency agency that any of these operations and plans have to be shared with your and created in cooperation with your local regional agencies. CMS states that the facilities have the options of including as part of their requirements additional accreditation, local or state or federal. Well, that makes sense because when it comes to emergency response, CMS is, no disrespect, but CMS is not the only authority you have to comply with. Undoubtedly, your state and possibly even your local region has ordinances and standards that you have to comply with that may be above and beyond what CMS is requiring. So that what they're saying here is essentially that that's fine. You can roll all those issues into the same process, into the same emergency operations plan. Now, CMS does go on to describe that their program is based on an all hazards approach, and the definition of an all hazards approach to emergency management is that it focuses on the capacities and capabilities of the healthcare facility, what you can and cannot do, and it does not exclude or limit a response to any particular specific type of emergency event. There was a time years ago that hospitals were only really preparing for, say, a mass destruction type of disaster or some certain type of disaster. And years ago, they started saying, we got to get away from the fact that a disaster that's going to affect the hospital will only be this disaster. It could be any disaster. It could be a tornado, could be a civil disturbance, it could be a terrorist attack, it could be a man-made situation, a burst pipe, it could be whatever. But the problem is that what standards were written in the day, back maybe 15, 20 years ago, really didn't identify that disaster preparedness has to cover every type of disaster. You have to be ready to respond to anything that happens. So that's why they've changed this and defined this as an all hazards approach. Now, in their final rule, CMS conceded that healthcare facilities could rely on a community-based hazard vulnerability analysis developed by other entities. Now, this is not uncommon in some communities where the HVA is actually a community event where it's filled out and completed by multiple entities representing the community. And that's CMS is saying, okay, if that's your approach, that's fine. But the bottom line is it does have to be realistic and relevant to your facility. So make sure that if you are using a community-based risk assessment, that it does have applicable issues addressed to your organization. All right, we're going to transition again into the policies and procedures. It's important to note that CMS actually says that policy and procedures may be standalone documents or they may be integrated in with the emergency operations plan. If you do choose to have them as standalone documents, then they have to be referenced into the emergency operations plan so that a person who's reading the emergency operations plan will know where to find the standalone documents. To be honest with you, most hospitals like to add them into the emergency operations plan so that they're just all integrated into one document so people don't have to search around for multiple different documents. But you can do whatever works best for you. So again, just like the emergency operations plan, the policies and procedures must be based on the planning activities of the program, such as the EOP, the HVA, and the communication plan, which we've yet to start to talk about. Policies must address the provision of alternate sources of energy. So you have to have some sort of way to control the temperatures of the environment, the lighting, and any of the fire detection and suppression system. Hospitals primarily rely upon their emergency power generators to provide the alternate sources of energy for these things. The issue here is that the bigger hospitals, the older hospitals, they're not. The emergency power does not provide power to the entire facility. It's more to a select branches, select pieces of equipment that are operating on emergency power as opposed to the entire facility. Therefore, in the severe weather climates, there may be certain parts of your facility where you cannot control the temperature of that area because it's not on emergency power. So if that's the case, you need to know where your emergency power limitations are, what is not on emergency power, and what plans you're going to take, what alternative measures you're going to take to facilitate your patients if you can't control the environment in those areas. So if it's a short-term duration, say 1 day, you could probably get by for a while in some areas without any type of HVAC. If it's a mild climate at the time, but in the severe climate, and if it's an extended period of a power outage, you're going to have to relocate those patients, get them out of there, and then where are you going to relocate them to? So this is something you have to be planning on and provide an explanation in your EOP. The policies must address the provisions of sewage and waste disposal, including solid waste, recyclables, chemical, biomedical waste, and wastewater. Now, CMS makes it very clear. This does not mean you have to have your own sewage disposal system on site. You just have policies on how you're going to have to address it. So there are many different ways of dealing with disposal of this waste if your system is impaired. So that's what you need to write into your policies, how you're going to do that. Policies must address the safe evacuation from the hospital, which would include the consideration of care and treatment of the patients, what responsibilities the staff is going to have during this evacuation, how are you going to transport those patients to their alternate care site, identification of evacuation locations, so you got to identify where you're going to evacuate them to, and how are you going to communicate through your primary and an alternate means of communicating with these areas. So this one slide is really busy. There's a lot of information here that you're going to have to provide in your policy. So you're going to have to identify the responsibility of the staff during evacuation, how you're going to transport them. You know, if you're going to use the local ambulance service or school buses or maybe somebody's 56 Ford station wagon, however you're going to transport these people. You're going to have to identify the locations where you're going to take them to. You may be evacuating to a neighboring hospital 30 miles away that is not affected by the disaster, or you may be moving them down the street to the basement of a local church or school, something like that. So these have to be identified in your policies as to what your plans are. You must have a policy that addresses the means to shelter in place for patients, staff, and volunteers who remain in the facility. So even though you may evacuate some, if not all, of your patients, you still are going to have people in the facility, and you're going to have a policy on how you're going to shelter them. Well, you may you may say, well, we'll set up cots in the dining area or a conference room, and put up some place there for maybe mattress on the floor and that type of thing. And if you choose to do it that way, then the surveyor may say, okay, show me where you're storing these cots. Show me where you're storing the linen and the bedding and the mattresses for these locations, and how many are you going to be providing sleeping arrangements for. So if you say you're going to do it, make sure you have the physical equipment in the building in order to do it. If you say, well, we're going to order that up from the local Army resale store, no, you can't do it that way. You got to actually have this information on site in order to provide this service. And don't forget that you have to provide for their safety. So you got to have some means of ensuring that the people are safe where you're going to shelter them. Well, let me go back there. This sheltering is for patient, staff, and volunteers. This is not a means of sheltering for the homeless or the indigent people or the people who come to the hospital because they need shelter. At one time during their a proposed rule, CMS actually was saying that you're going to have to do that, and a lot of people objected to that, so they retracted that, and they're in a position now saying that, well, that's not part of the deal, that we decided not to require that. So you don't have to worry about providing shelter for people who are seeking shelter that are come to the facility. That's no longer a requirement. Policies must address a system of medical documentation that would preserve patient information. So you're going to have a system dealing with the medical records of patients. Now, if you have an electronic system, which many hospitals are moving towards, that's all well and good, but what happens when that electronic medical record is no longer operating due to interruptions of access to it? So I'm sure that those hospitals that have the electronic records say, well, we have a alternate way of dealing with that. We come up with paper copies, the old-fashioned paper copies that we've used, for decades. Well, good, but keep in mind, and I've seen this actually happen at the facility where I used to work, where they had medical records, and people got so used to the medical records that when that system went down, they had to rely on paper copies. Number one, they didn't know where the paper copies were at. Number two, they weren't that familiar with filling it out. It had been many years since they had to fill it out. They actually had new people that came in to work that never have seen the paper copies before. So it was a huge backlog of information gathering and recording because people were not familiar with it. So if you're relying on the paper copies in lieu of electronic records, then I suggest that you have annual training for people to be familiar in how to use it. Policies must address the use of volunteers in emergency or have other emergency staffing strategies. So this includes the role for integration of state or federally designated healthcare professionals to address surge needs during an emergency. Many states have systems set up where licensed professionals can register their credentials so that during an emergency, when they show up to, I'm a licensed professional, I'd like to help, it's a very quick way of securing their credentials and confirming that they are who they say they are. So that is important that you use that in the volunteer phase. Policies must address a process for development of arrangements with other hospitals. So other hospitals, all hospitals are required to have memorandums of understandings with other hospitals to receive patients in the event that the hospital has to cease operations. So you're going to find that this is going to be something that other hospitals are actually going to be eager to enter into agreement with you. There should not be any resistance, even if they're what you might consider their competition. So the hospitals are required to have this agreement. So they're very undoubtedly will be very willing to sign an agreement with you on that. Essentially, that you're saying we'll accept each other's patients during a disaster. That's obviously if you're capable. If you have the same disaster that your neighboring hospital has, then obviously you can't receive their patients. Policies must address the role of the hospital under what they call a Section 1135 waiver. Now, when the Health and Human Services Secretary declares a public health emergency, the Secretary of HHS is authorized to take certain actions to waive or modify the certain requirements for Medicare, Medicaid, and Children's Health Insurance Program. Now, what this means is that once the 1135 waiver has been declared, and it has to be declared by the Health and Human Services Secretary, this allows hospitals who provide services in good faith to receive reimbursement for those services like they would normally under Medicare or Medicaid program, even though their facilities have been severely disrupted and no longer meet the requirements, specific requirements of the CMS standards. Now, this is all due to this is all in lieu of any absent any determination of fraud or abuse. So what happens is, what they're looking at is a scenario where a hospital has to relocate some of their patients to an alternate care facility, an alternate care site that quite frankly may not meet the requirements for a hospital. So if you have to receive patients at a local church or a local school because your ER is over inundated or you become damaged and you can't receive them there, but you still provide services that normally would be reimbursed through Medicare or Medicaid, what this 1135 waiver allows you is to continue to receive the reimbursement even though you technically are not meeting the requirements of Medicare or Medicaid. Now, in order to secure this 1135 waiver, you do not have to apply for it. You just have to declare that you are under the 1135 waiver, and you declare that by sending an email or a letter to the CMS regional office in your region, and you copy your accreditation organization. Once you do that, then it's declared. CMS regional office will handle that and ensure that you continue to receive the reimbursements that you're entitled to. Now, CMS does believe it's best practice for hospitals to prepare to provide subsistence to individuals in the community, but they do not require it. This is what I was referring to earlier, that if you have indigent people or homeless people or people who are seeking shelter that come to your facility, at one time CMS thought that that was something you are going to be required to care for those people. A lot of organizations and hospitals objected to that because that would be something that would be nearly impossible to provide. So CMS backed down from that, and they said, well, we consider it best practice, but it's not a requirement. So I wanted to clarify that. All right, so now we're going to transition into the communication plan. Just like the other policies and procedures, the communication plan is allowed to be a standalone document, or it may be integrated with an EOP. If it's not integrated in the EOP, then it has to be referenced as to where it can be found. Hospitals are required to develop and maintain an emergency preparedness communication plan that complies with federal and state law. There may be additional requirements through your state agencies that you have to comply with certain things that the CMS Emergency Operations Plan does not require you to comply with. So whether you have FEMA or Health and Human Services regulations or maybe a state regulations, all of these have to be part of your communication plan if you're required to comply with it. Just like everything else, the communication plan has to be reviewed and updated and include information on an annual basis. I mean, updated on an annual basis. It has to include contact information for the federal, state, and regional staff and other sources of assistance. So you have to identify any of these federal, state, regional agencies that you have to communicate with and plan with regarding the communication aspects. You got to have all that into the plan. So the communication plan has to include names and contact information about staff, entities who provide service, and any of the patient's physicians and other hospitals and volunteers. So just about anything and anybody dealing with emergency, you have to have their contact information. You got to identify the primary and alternate means for communicating with the hospital staff and other emergency management agencies. This gets into some really tricky situations because I've seen some emergency operations plan that pretty much is saying, well, we will communicate through telephones, but if the telephones don't work, we'll communicate through cell phones. Well, if anybody's ever had an experience of any type of regional disaster or emergency, they'll soon realize that the cell phone towers, if they are still standing, get over inundated, and it's almost impossible to get a phone call through a cell phone tower when everybody who owns a cell phone is trying to use it. So don't rely just on landlines and cell phones as your only means of primary and alternate means of communicating. So you got to come up with alternate ways beyond that. So it could be ham radio communication, could be two-way walkie-talkies if you're communicating with an alternate care site that's nearby. You need to come up with alternate strategies. The communication plan must also include a method for sharing information and medical documentation for the patients that comply with the HIPAA requirements, I might add. Other things that are included in the communication plan: a means in the event of an evacuation to release patient information, a communicating system capable of generating timely and accurate information about the patient that could be disseminated to others. And what that means is that your regional entity may want a list of patients and their injuries and situations so that they can keep track of that. You have to have a means of providing information about the general condition and location of patients under your care as permitted under HIPAA rules. Now, HIPAA does permit that. If you look at the HIPAA rules, they do allow you to release general information and condition about patients to certain entities and certain people, so you need to be aware of that. And you got to have a means of providing information about the hospital's occupancy, what the needs of the hospital is, and the ability to provide assistance. So the outside agencies that are coordinating disasters, they need to know if your hospital has got, if you're at 50% capacity or 100% capacity, or if you're saying, hey, don't send us any more patients, we're full, whatever the case may be, you have to communicate that information to these agencies on a frequent basis. Now, it needs to be explained further that the comment in the CMS final rule, it says, a method for sharing information and medical documentation for the patients under the hospital's care with other healthcare facilities. It does not mean that you need to go out and implement costly changes with your medical records system. It's apparent that not all electronic medical record systems will communicate with each other electronically. So essentially what they're saying here is that you can just print out the medical records on the paper that's relevant for that patient, put it in an envelope, and then send it along with the patient. All right, so let's look at the final phase of the emergency management program, which is training and testing. The training program must include an initial training in emergency preparedness, but also include an annual review and update on the training. This aspect of this requirement, what it says initial training, is creating quite a reaction among many hospitals. Here's the situation. CMS is flat out saying that here's our standards, these are brand new standards, prove to us that you've provided initial training to everybody in your organization on these emergency preparedness based on how it applies to them and them doing their job. Well, hospitals are doing this frequently on an annual basis as far as your annual validation, annual training. They have oftentimes they have computer modules, and they include a segment on emergency preparedness or emergency management, and they have this. That is not what CMS is referring to, because anything that you've created up until this point does not include these new requirements that CMS is making. So CMS this is one of those FAQs that they've talked about. They are very adamant. They want to see, as of November 15th of 2017, they want to see that you have provided the initial training, and that's the date you need to have it provided by. You have to provide the initial training on emergency preparedness to everybody who's involved, who their job responsibilities are involved in emergency response. So this is a one-time training from my point of view that you need to create and provide for everybody. How you do it is up to you. It could still be through the computer modules. It could be through a safety fair. It could be through individual staff meetings. Whatever you choose to do, you still need to have an initial training that shows that everybody who participates, everybody by job description participates in an emergency preparedness and emergency response, must have initial training on the CMS standards by November 15th, 2017. I want to make that very clear, because a lot of hospitals are pushing back on this and saying, oh, this isn't what we should do. A lot of people are fighting this and saying, no, we don't want to do this, or this is not right, or do we really have to do this? CMS has made it very clear. This is what you have to do. And quite honestly, any of these organizations that come and inspect you after November 15th, 2017, they're going to, this is a low-hanging fruit. They very likely will ask you, show me that you provided initial training to everybody in your organization. Now, how deep they get into that is up to them. They may want to see documents for everybody who's involved with emergency response, but this is something that you're going to have to provide. Then, on top of that, after you do that, now you have to do annual training and review for the same people that you just trained initially. Now, the annual training could be any time during the calendar year, but it should be 12 months within that initial training. So be prepared, get ready for that. This is August 1st. You've got a couple months to get that done. Make sure you get it done. The hospital must provide training and emergency preparedness to all new and existing staff, including individuals providing services under arrangement. So that's your contract people. Could be contract physicians, but it could also be contract nurses. Could be contractors who are involved in emergency responses that we haven't identified yet. And any volunteers consistent with their expected roles. So if you're relying upon your volunteer staff to participate in the emergency response, then they need to have this training as well. And again, once it's established, then you have to redo it on an annual basis. You have to conduct 2 emergency exercises a year. They call them drills or emergency exercises. And the purpose is to test your emergency plan. The first exercise must be a full-scale exercise that is community-based. But CMS is very clear. When they say when a community-based exercise is not available, the hospital must conduct an individual facility-based exercise. So this is a good thing, because they're acknowledging that there are many hospitals across the country that are located in certain regions where that particular region does not conduct a community-based exercise every year. So if that's the situation for you, then in lieu of the community-based, then you must do the facility-based exercise. Then the second exercise is required to be a full-scale exercise that is facility-based exercise. So you got to do 2 a year. If the hospital experiences an actual natural or man-made disaster during that requires activation of the emergency plan, then the hospital is exempt from engaging in a community-based or individual facility-based exercise for 1 year following the onset of the actual event. So they're giving you credit if you do participate in an actual event, then you don't have to do one of the 2 required drills. Now, CMS does allow tabletop drills to qualify as one individual facility-based exercise. But be careful, because many of the accreditation organizations do not permit tabletop drills in lieu of the actual exercises that you have to do. Hospitals must analyze their response. So you have to do an after-action report. The after-action report is essentially you have to maintain documentation on all drills, exercises, actual emergency events, and tabletop drills, and revise the emergency plan as needed. So the after-action report actually has to have a recommendation or a conclusion, and for any changes that are necessary for the emergency plan. Now CMS states the hospital's training materials and testing exercises would be reflective of the hospital's HVA. This is interesting because if you had continuously performed emergency exercises based on, say, severe weather hitting your region, and if that's the only thing that you ever drilled time and time and again, then that implies you're not addressing the other issues in your HVA, because your HVA has to identify more than just one potential disaster to your organization. All right, so we now examine the 4 core elements: planning, policies and procedures, communication, training, and testing. So let's look at the rest of the new requirements for emergency management. Now, in their proposed rule, CMS stated they wanted all hospital emergency power generators to be load tested for 4 hours each year. Well, currently hospitals are required to do a 4-hour load test once every 3 years. Now, fortunately, in their final rule, CMS rescinded this, and they said that that is not required. And they feel that the once every 3-year test for 4 hours is sufficient. So no additional requirements regarding this. I wanted to make that clear because it was highly discussed during this proposal phase, and CMS heard those comments and they relented on that particular issue. Hospitals that build new structures or renovate existing structures or install new generators are required to place a generator in a location that would be free from possible flooding and destruction. This is a tough one. So if you have your generators in a basement, you're pretty much going to have to get them out of the basement when you replace your generators, or when you're building new structures, because basements are susceptible to flooding, whether it's an internal flood or through an external situation. But if you put the generators in a self-contained enclosure in your backyard, well, how's that going to stand up to severe weather? So you have to be careful as to where you consider relocating these so they're not in an area that would be susceptible to flooding or destruction. Hospitals that maintain an on-site fuel source to the generators must have a plan on how you're going to replenish that fuel, unless that the hospital is going to evacuate at that time. So this plan may consider the replenishment fuel outside from outside sources. So you should have memorandums of understandings with probably more than one source of fuel for your generator, so that given an emergency situation, you would have at least one source, hopefully, that would be able to provide you with fuel. Contrary to their proposed rule that CMS issued, they will now allow separately certified healthcare facilities that operate within a healthcare system to elect to be part of the healthcare system's Unified Emergency Preparedness System. Now, what does this mean? Well, there are many hospitals out there that are part of a corporate structure. They have one corporate entity that is overall, but each hospital is a separate entity in itself, and they have their own CMS certification numbers, and they are certified separately, not as a whole system. Apparently, I'll be honest with this, I missed this one and I didn't read this in the proposed rule, but apparently in the proposed rule, CMS said that if you are part of a major system but you have separate entities, separate CMS numbers, then you cannot be part of the unified system for emergency response. Well, these hospitals objected to that, and they said, look, there's value in us being part of this corporate structure of response for emergency preparedness, even though that we are separate entities amongst ourselves. And they finally said, okay, that makes sense. So they relinquished that requirement. So now integrated healthcare systems are permitted to operate under a unified plan. Transplant hospitals, this is something that, quite honestly, has never really been addressed in emergency response before. If a hospital has one or more transplant centers, a representative from each transplant center must be included in the planning phase of the emergency preparedness program. Kind of makes sense. I'm not sure why they needed a special standard on it, but that's fine. Also, for transplant hospitals, the hospital must develop, maintain mutually agreed upon protocols that address the duties and responsibilities of the hospital, each transplant center, and the organ procurement organization for their donation service where the hospital is situated. I think that's kind of a given. That's already a requirement. All right, so those are the standards. That's the new stuff that CMS has actually printed. I don't think it's overwhelming. I think it's quite straightforward. I think it's kind of a thin amount. In other words, there's not a lot of fat to these standards. I don't think there's hardly anything here that is unreasonable on CMS's part. Overall, I think it's a good idea. I think they've done a very good job. It sets minimum standards for all organizations, healthcare organizations to follow. It's apparent to me that CMS took their time and did a very thoughtful and careful aspect of the emergency management and created these standards. In all, I think they did a good job. I know that the accreditation organizations will incorporate these new standards into their emergency management chapters, but I also expect that the accreditation organizations will retain many of their previous standards that they think are important. CMS is okay with this because that means the AOs are meets or exceeds the minimum requirements. So you can see, like now, as an example, Joint Commission has in their emergency management program 4 phases of emergency management: mitigation, preparedness, response, recovery. Although I've not seen Joint Commission's new standards or pre-publication standards on emergency management, I would be surprised if they did away with any of these, because these are good. These are sound principles, and I think they're very worthwhile having, and I expect Joint Commission would keep these as part of the emergency management. Hospitals that are accredited by one of the major AOs will see a lot of similarities with these new standards, and the transition over to this new requirement should be stress-free. I don't think there's much more than, say, if for one person, more than a couple days' work in order to rewrite the policies and get everything that's in line. But hospitals that are not accredited and they rely on their state agency for certification for CMS may find it very challenging to incorporate all these new concepts because, quite honestly, until now, they've never had to deal with this. So whoever you are, if you fit into one of those molds, you should be in a preparation phase to get this going. Hopefully, your AO will have pre-publication standards soon. I know that HFAP has theirs out, and many people have been reviewing and commenting on. I have not seen Joint Commissions yet, so if they're out, I have not seen it, but hopefully they'll be out soon if they aren't. The sooner you get a chance to review these pre-publication standards, the sooner you have a chance to become compliant. Okay, that is my presentation. Joe, I'm going to turn it back over to you for any questions that the listeners may have. Joe, have you unmuted your phone?
Are we there?
I can hear you.
Well, I'm sorry. I don't know what the heck happened on our end. Is everyone joining us still? All right. I do have some very good questions. I want to thank everyone who emailed in your questions. If we don't get to them individually, we'll be sure to send some response to you via email. But Brad, I have quite a few good questions. And the first one that came in is if the Joint Commission's emergency management standards are more restrictive than CMS's new emergency management standards, can we be excluded from having to meet the CMS emergency management standards?
The answer is no. You are not excluded from meeting the CMS standards at all. If you receive Medicare, Medicaid reimbursements, you have to meet all of CMS's conditions of participation. But the issue is the Joint Commission standards will, as of November 15th, will meet or exceed the CMS requirements. So by meeting the Joint Commission requirements after November 15th, you would, in essence, should be meeting the CMS standards for emergency management. So what that means is that if you do everything the Joint Commission tells you to do and you do it 100%, then if a state agency comes in and evaluates you, you can show them your Joint Commission responses, your management plans, and so forth, EOPs, and they should accept that because that should be meeting all of CMS's requirements as well. I hope that answers your question.
Fantastic. And another one here, how detailed does the training have to be for all of our staff?
My gut feeling is it's awareness training. It is not detailed training. Another way of putting it is that the level of detail is dependent upon the expectation of the individual's response during a disaster. So if you have emergency room technicians that are expected to decontaminate patients that come to your facility, then yeah, you got to train them on how to operate, set up, and operate the decontamination process. But a housekeeper who is no longer, their duties are suspended during the disaster and they're used as maybe people who will direct traffic or be a hallway monitor or something like that, then no, you don't have to train them to a higher level of detail. So it's dependent upon the expectation of the person's title and job description of what you expect them to do during a disaster.
All right, thank you. And another one here is how do we write a policy on volunteers when we don't know who will show up to volunteer?
I didn't cover this in my presentation, but I've had a couple hospitals flat out tell me, says, Brad, we wrote it in our plan, we are not going to accept volunteers. Their policy says we will turn all volunteers away, we will not accept any volunteers, we will do everything with our own staff. Now, I'm not advocating that as a plan, and I said, well, why are you saying that? He says, because we don't know how to deal with the liability insurance. So if a licensed professional comes in and says, I'd like to volunteer, okay, the question is whose malpractice insurance is being covered there? Does the hospital's malpractice insurance expected to cover that individual, or is the individual's malpractice insurance expected to cover that individual? Those are questions that are tough to answer, and quite honestly, some agencies are not getting adequate answers to those questions. So they say, okay, we just aren't going to accept any volunteers. Now, the way you write a volunteer plan is with the expectation, are you going to accept volunteers or are you not? If you decide to accept them, then you will identify, then the plan is they will be supervised by one of our staff. You will never leave a volunteer licensed professional or non-licensed professional operating on their own. Operating means providing their service on their own. So you would then have them be supervised by a staff individual. So you would say that. You would use them only in limited roles. Let's say we will only accept volunteers for this type of service. So you've got to have a plan that discusses that. So at the time of the disaster, you're not figuring out what we do and what we don't do. It's already written down explaining what we will do.
Okay. And I've got a couple folks here that have asked, how do we apply for an 1135 waiver?
You do not apply for it. The 1135 waiver will be declared by the Secretary of Health and Human Services. Once it's declared, then you write an email or a letter to your regional office, your CMS regional office, and you copy your accreditation organization, and you say, we are invoking the 1135 waiver at our facility because our facilities are not capable of providing all services required on a Medicare Medicaid. Then that is recorded. That's on record. You are there. So if CMS comes back 3 months later and says, wait a second, we can't reimburse you for these services because you did them at the church down the street. He says, yeah, but the 1135 waiver was invoked, and here's our copy, and this is what we did, and the regional office knows about it, so it's all covered. So it works like clockwork, right?
Right. Okay, and then another good question. I see this twice. It says, does the 2 exercises per year requirement apply to all occupancy NFPA 101 types?
No. It applies, and this is the differences. When I said there's differences, it applies to all hospitals and critical access hospitals. It applies to, I believe, ambulatory surgical services. Ambulatory surgical. Today I'm having a stumbling block. To surgery centers. It does not apply 2 a year to physicians' offices. So you only have to do 1 a year at physicians' offices. That's as far as I'm going to take it because I didn't research it any further than that.
And then I have another one here. It says, when you talk about the training requirement by November 15th of this year, does CMS expect the facilities will have already performed the drills by that date? Or is it more akin to compliance and HIPAA training, not hands-on, but informational? Question mark.
Yeah, that's a mouthful there. The November 15th date is the date that you are required to comply with the requirements. So that means at that date you should have had all the training done that is required and all the exercises done that is required. So you have to have your 2 exercises done by then for the previous 12 months or the previous calendar year. You got to have your initial training done. That includes the initial training on the new CMS requirements. I'm not sure I understood the rest of that question. Did that cover everything in the question?
Yeah, I believe the last part was, or is it more akin to compliance and HIPAA training, not hands-on? So,
well,
yeah.
The level of training would be dependent upon the expectation of the individuals. We didn't even talk about NIMS training, but NIMS training is more about awareness training. And I think that is part of what CMS is referring to. But you also have to have documentation that the people who have need for hands-on training receive that on an annual basis. So it's mostly dependent upon the expectation of the person's job description during a disaster.
Okay, and I've got another one here. How does CMS define full-scale exercises?
Well, that would be something that would make a surge in your facility. And this is Brad's interpretation. I'm not reading anything off the CMS wire. But that would be something that would require an influx of simulated patients, whether you have actors or moulage, or if you have paper patients, and then you move them from one department to the other. But something that requires an influx and a change of operations in order to accommodate the exercise.
Okay, and I see going through it here, quite a few have been the same, and you addressed them, but here's another one. I think I understand what this lady here is asking. She says, can the policy requirements be addressed in the EOP, or does it need to be a policy such as for evacuation? Well,
Say that again, please.
Yeah, I'm trying. Just can the policy requirements, just a couple of typos, you've typing fast. Can the policy requirements be addressed in the EOP, or does it need to be a policy such as for evacuation or SIP?
Well, I'm not sure I understand the question, but the policies that can be freestanding, separate from the EOP, or it can be integrated into the EOP. If it's freestanding, then it has to be referenced in the EOP as to where to find those policies. Does that answer that question?
I believe so, and I'll just say the first name, Davina. If you'd like to type in the rest, if you're still with us, and clarify your question, I'll ask Brad right away. One more here, Brad.
You just identified her as a bad typist. That's careful,
no,
Joe.
I said a slip. Hey, what would be the scenario for an AFC to accept patients into their facility in these disasters?
Well, I wouldn't go down that road. That would be a full-scale disaster. I would be very cautious making any statements about accepting patients under a trauma or emergency basis, because you're not prepared for that. You're not in a position to do that. Obviously first aid is one thing. If somebody is bleeding and got a contusion or has some sort of need for first aid, that's one thing. But if you're talking about actual trauma patients that require emergency services, you're opening yourself up to a can of worms there. I would suggest that you not make any statement saying that you will receive those types, because quite honestly, once you do, then you have to have the expectation is that you would be prepared for that. That means you would have to have essentially some sort of setup that is equal to an emergency department, and that's not what you're in a position to do. So my advice is steer away from that and not identify that in your plan.
Okay, and I have one more good question here. It just came in. It says, Brad, can you please elaborate on the integrated system information specifically for hospitals that have various campuses and also have the same license number? Do they require different plans, or is one plan acceptable to meet the criteria?
You can do it either way. In fact, depending on the location of these different campuses, you may have to have a different HVA. For the main hospital, you have one HVA, but if you have a facility that's 12 miles away and it happens to be in a close proximity to a refinery center, then the potential disaster is somewhat different, and it's pretty obvious there may be a different response needed at that second facility that doesn't apply to the main facility. But other than the HVA and any policies that are driven from the HVA as far as the difference in it, it would be pretty much the same. But the answer is you can still have separate EOPs for the same certification number facility if they have different campuses. So you can have separate EOPs for separate campuses even though they share the same CCN. That's fine. Whatever you choose to do, you can have the same or different.
All right, appreciate it, Brad. Well, I think a lot of them here are repetitory after that. I'd like to thank everyone today for joining us in the presentation of the webinar. There's a lot of questions here that ask if this information will be available. And yes, you can find all the information, the slideshow presentation today on our complianceonegroup.com website. We will make that available to you soon, hopefully by the end of the day today, if not maybe by tomorrow. And make sure, please, when you go to that site, that you sign up for future notifications on trainings we'll be hosting. And next month's session, we're going to focus on compliance regulations centered around barrier management. Our topics will be such as doors, dampers, fire smoke barriers, penetration, and the documentation required to maintain compliance. As many of you already know or utilize, our software partners, eMeditrack, also known as Solarian out of Kansas City, will be joining us on that webinar. And we together are looking forward to providing educational resources and solutions for all of you in the healthcare market. And finally, I'd like to say is, and I know no one likes to do it, including me, but we're going to put a short 5-question survey out to everyone. I hope that you answer it. And I appreciate some of the really good comments that came across from all you folks saying that you've listened in on several of these webinars so far. And Brad, I'll just tell you that most people are more than complimentary, saying you explained it better than anyone they've heard so far. So we appreciate your time, Brad. Yeah, it was very good. And we look forward to doing this again with all of you next month. So thank you, everybody, for your time today, and have a great rest of your Wednesday. Thank you, Brad.
Thank you very much.
Bye-bye.